Rheumatoid arthritis treatment. In the previous video, we covered about the diagnosis of the rheumatoid arthritis, in which the Euler criteria are to be used, the 2010 criteria, and now we will discuss about the treatment. Principles of management. Now, in the previous criteria of the 1987, we used to follow a gradual upgrading of the treatment, which was called a pyramid, uh, not a pyramid scheme, in fact, it was a pyramid treatment. Now, in the new criteria of 2010, we follow an inverted pyramid in which we attack the disease early and we attack it hard and gradually scale it down to bring remission in the patient with the least amount of medicines. Now, the principles, there are three main principles. First of all, you have to diagnose the case early, in which you have to use the Euler criteria as discussed in the previous video. Secondly, you have to treat the patient with early induction of DMARDs, the disease modifying anti-rheumatic drugs. And thirdly, you have to have a target in mind so that you can maintain a low disease activity in that rheumatoid patient. You have to achieve that LDA, and then only you can think about scaling down the treatment. So these are the principles. Now, why is this early diagnosis and treatment critical? Until 2010, the 1987 ACR criteria were used to diagnose RA. However, these were useful to diagnose only established RA, when in all probability the joint damage would have developed, defeating the very idea of preventing or retarding the joint damage with early treatment. Hence, the 2010 criteria were developed to overcome this shortcoming and are now used to diagnose early RA. And over the years, the concept of early RA has evolved from a period of 3 years to that of 3 to 6 months. And pushing this concept of early diagnosis further carries the inherent risk of treating patients with undifferentiated arthritis who would otherwise will not develop RA. But there is a good rationale in the studies being conducted that the Euler criteria have prevented damage in most of the patients, and ultimately those patients prospectively have become RA positive, even in cases of seronegative RA. So the first strategy is to treat to target, T2T. It is called T2T. It is the presently accepted concept to treat RA, and it implies that we have to treat the patient to achieve a decided target, which is the LDA, low disease activity. Now, the active disease patient, when the patient is in active disease, you have to follow him up frequently within 1 to 3 months intervals, so that you are able to modify the therapy, either the dose or the frequency of the medication, till your target is achieved, which should ideally be achieved in 6 months. Okay, then you switch on from the active phase to maintenance phase. In this, the treatment is scaled down to a level that continues to keep the disease under control, and then the number of drugs are decreased. Now, what is this LDA that we're talking about? Now, LDA can also be called as your remission, the target of remission, or the low disease activity. This is your therapeutic target. Remission is defined differently by different criteria, and the most commonly used is DAS28 score. And the LDA accepted as target when remission is not possible, like you're in a long-standing disease where your rheumatoid has already damaged the joints. So in that case, you cannot achieve remission. You have to continuously put the patient on DMARDs. Now, little definition. Remissions, as per the present definition, does not mean 100% complete remission, because MRI or ultrasound can still detect some synovitis. So this remission is basically your clinical based. Also, they do not take into account the joint damage and functional capacity of the patient. This is basically your symptomatic scoring. Okay. So these are this box shows your various scores used to calculate your remission. Now, the most commonly used is your DAS28 score. You have a Android and Apple based apps for this calculating these. You don't have to go into learning the criteria of this. You just have to know that remission target is at less than 2.6 value. Okay, rest of the values can be easily seen in the app. Now, the treatment, the pharmacotherapy of the treatment. Mainly 3 types of drugs are these are very simple. Firstly, your NSAIDs, your non-steroidal anti-inflammatory drugs. Second is your corticosteroids, or number 3 is your DMARDs. First of all, NSAIDs. They have the both anti-inflammatory and analgesic action. However, they do have a drawback that they do not have the disease-modifying action. Plus, they have GI side effects, cardiac side effects, renal side effects, and in elderly, NSAIDs should be given only if absolutely necessary. Among these, the selective COX-2 do have some advantages. And point to be noted, the analgesic effect of the NSAIDs is not dose dependent. That means it has a sealing effect. That even if you increase the dosage of the NSAIDs, the the painkiller action will not increase. Hence, if the patient has persistent pain, you have to use add-ons like PCM or tramadol for the analgesic action. Now, the corticosteroids, second pharmacotherapy that we commonly use is a corticosteroid. These have the advantage of that they act rapidly and they do have a disease modifying potential. The present indication is basically is a bridge therapy because they decrease the symptoms with much efficacy and with much speed, and hence it helps you to tide over the time required for DMARDs to start acting, which is usually about 3 weeks time. Now they are given as a pulse therapy or maybe sometimes as intra-articular steroids. Prolonged therapy may be required in some patients, but it has to be usually avoided, and prolonged load is may be required in some patients. Now the DMARDs. The DMARDs have been categorized as into 4 types. First is your conventional synthetic DMARDs, which is the methotrexate and leflunomide, most commonly used drugs. Also sulfasalazine and hydroxychloroquine. Those also nobody is using these days. And second is your biological DMARDs. These are the TNF inhibitors. Your infliximab, etanercept, golimumab, adalimumab, setrusumab, and the other category is your anti-CD20, of which rituximab is famous. Then others anti-interleukin 6 receptor antibody, tocilizumab, anti-interleukin 1 antibody, anakinra, and so on. Third is your targeted synthetic DMARDs, which includes the new kid on the block, this tofacitinib. Number 4 is your biosimilar, not biologicals, but biosimilar DMARDs, which are equivalent to the biological DMARDs, but they are relatively easy to make once they show their therapeutic effect. Now, the first and foremost point to be discussed in the treatment is their what to give the patient, either monotherapy or a combination therapy. Now, most authorities they do recommend the combination therapy, the combo therapy, which has usually 2 to 3 conventional synthetic DMARDs as the initial therapy, with methotrexate is the as the anchor drug, okay, over which you can build up your treatment plan. Now, the advantage of this combination therapy is that it is more efficacious, certainly because you have more drugs, and at least not more toxic. Okay, the toxicity levels are comparable. Hence, it has more therapeutic effect while giving you the less amount of side effects. Indirectly, it also does reduce the cost of by decreasing or delaying the need for biologics. Yeah, that is also a positive point on this combination therapy. Now, switching therapy. When to switch the therapy? This act is usually required when we have a failure to achieve the target at 6 months, or the patient develops intolerance to the drug, in which case you have to change the drug before 6 months also. Usually leflunomide and sulfasalazine are used, and both are used as a replacement drugs for methotrexate. Okay, so most common triple therapies that we use are methotrexate, SARS and HCQS, or lefno, SARS and HCQS. This is the triple therapy that we switch over to when we are not able to achieve good result with the combination therapy. Now, biologics and methotrexate are given when the triple drug therapy also fails. Okay, when the patient is not able to, firstly you start with a combination therapy, okay, of which methotrexate has to be essentially given, and it may be added with either one of the DMARDs. Usually it is HCQS. Okay, then we come over to when the patient is either inadequate response or intolerance, or we are not able to achieve a target, then we should switch over to the triple drug therapy, in which most combination uses lefno, SARS and HCQS. And when a patient is not able to give remission in this also, then we come on to the biologics, and usually a combination of biologics with methotrexate is given. Then when do we shift to other type of DMARDs? When like tofacitinib is given when this both of this combination fail, meaning the next step is your tofacitinib, and biosimilars are may be substituted for the corresponding primary generic biologics to decrease the cost of therapy. Now, scaling down and withdrawal of the treatment. When do we decrease the treatment of the patient? This is considered when the remission is achieved or the low disease activity has been maintained for sufficiently long duration, which is usually about 6 months. Now, how do we do it? We do it by two methods, either dose reduction or decrease in the frequency of the drug. These are the two that we have, but dose reduction is usually followed, and the successful persistent remission of the treatment is more likely in the early RA than in the established RA, because some damage has already occurred, and patients does not become asymptomatic ever. Now the sequence of withdrawal is easy. Firstly, you have to give a low duration steroids, and then you have to stop your biologics, and in the end your CS DMARDs, mainly methotrexate. The meaning of this statement is that methotrexate has to be your last drug to be stopped. Okay, this is your anchor drug. Now the rationale of this whole treatment and the Euler criteria is that studies have seen that about 97% of the patients which have been started on methotrexate using these Euler criteria, even if they are rheumatoid negative and does not have radiological features, they have seen that they become uh, positively classified as RA, even based on your old criteria of 1987, within a span of 1 year. So these criteria are working and they are preventing disease in RA patients. Now the end of the topic is, there are still some unanswered aspects of this whole rheumatoid arthritis treatment and diagnosis. Firstly, it has not been possible to predict accurately an individual's patient's disease course and to determine the intensity of treatment indicated. Meaning, we have some prognostic indicators, like if a patient has a high rheumatoid factor or anti-CCP antibody value, then he is supposed to have a more severe disease, but you cannot quantify it. These are just qualitative factors. That's the first point. Second is, response to treatment cannot be predicted. Different patients respond differently. Thirdly, no matter which strategy is used, either mono or combination therapy, or which drug is used, the response rate is never 100%. Okay, it is not never 100%. So you have to have an open mind to change your therapy treatment. You have to be open to switching your drugs. Okay, and not one formula works for all. Now, next is, there are no biomarkers to predict the response to a specific drug, and this is also an area of active research. Lastly, there are some special situations, like which are the your false negative and false positive, which I discussed in the last slide, in the last video. So that is all. Thanks. I hope I added to your knowledge. Thank you so much.